This is my audience at the Columbus VA Clinic. Hello, my name is Debbie Moon. I'm going to teach you today and give you a little bit of education on the opioid crisis that we're going through as a country and as a nation. So the objective, by the end of this presentation, the learner will have a better understanding of the opioid crisis and how to treat patients in a more effective way. During my research, I read an article by Charles Lockwood. He says, like the road to hell, the road to the opioid crisis was paved with good intentions. And I believe that is true. I think that when they came up with the opioids, lots of people felt that it was a need and it was necessary. And it was intended to be used for cancer patients, terminally ill patients, patients that thoroughly needed this medication. And slowly but surely, it began to be used inappropriately for chronic acute pain that it shouldn't be used for. And during my research, I found that the terminally ill patients and the cancer patients are actually suffering more because they're not able to get this medication as deemed necessary because new protocols and new things have been implemented to keep from the abusers getting it. So it can hinder the ones that need it as well. Prescription opioids and heroin are chemically similar, and they work through the same mechanism of action. So we all know that heroin is very addictive, so are opioids. They work the exact same way. So I had some astonishing statistics I found, and I'm going to go just read through those real quick. 2.5 million Americans had an opioid use disorder. From either, there was 77 that was from prescription medications, 23% was from illicit drugs. So that's a huge number when you think of it, that 77% of those people was from prescription. In my mind, I think more that it would be from illicit drugs, but it's definitely not. The other 90 Americans died of an opioid overdose every day in 2015. The Oxycontin prescription soared from 670,000 in 1997 to 6.2 million in 2002. The other one, survey data suggests that 80% of heroin users began their opioid use with a non-medical consumption of prescription opioids. Drug overdoses, primarily from opioids, have now overtaken motor vehicle accidents as the #1 leading cause of unintentional injury death. That was shocking to me. I did not know that, and I thought that was crazy. So what effects does the opioid crisis have on the healthcare industry and us as a whole? It jams up primary care. You have people walking in every day wanting pain medication. It is using our tax dollars for this national crisis that could be going to something else. There's multiple providers are killed over pain medication, and people are actually committing suicide over not getting pain medication and the effects from withdrawals. Now, tax dollars are also used for Narcan. It's given out free to people. So those are some things that are affecting us as healthcare. So what are we doing to help this crisis? And when I say we, I'm talking about the Columbus VA Clinic. We are, let's see. Hold on one second. We are, they started an opioid safety initiative. They have developed policies and protocols for treating acute and chronic pain. They have had in-services on effective opioid management. They provide monthly drug screens. They have to have it. It's mandatory for opioid users. They have pain contracts that the patient and the provider sign together and go over. They do face-to-face
Hey, Devi, you have a call
appointments
on line 1, return call on line 1.
they do face-to-face appointments with the patients that are prescribed opioids, and the providers as a whole, I know at this clinic, they have really weaned patients, and they're trying really hard to get everyone off of opioids, which to me that almost seems impossible, but it's not. They are working really hard and diligently, and as a nurse here, I've seen it firsthand, the effects that come through. We get a lot of upset veterans, a lot of angry veterans, and it clogs up primary care, it bogs us down, and it causes a lot of kind of stigmatism, and it can make us feel like, you know, give the veterans a bad rap when they were started on this many years ago. And so they don't understand why the VA isn't giving them this medication anymore. So it's been a lot of education we've had to give here at this clinic. So, us as healthcare individuals, we need to know the signs and the symptoms of opioid disorder, because it is a disorder now. And that's lethargy, cognitive dysfunction, behavioral changes, mood swings, less personal attention, like not grooming, not bathing appropriately. Constricted pupils are one. So, how can you make a difference? And I geared this more towards providers. Nurses, I feel like we take on more of the education part, but providers are the ones that start the medication. And so one thing I kept reading over and over was start low and go slow, and that means the lowest effective dose should be started, and it should not be elevated very quickly. It should start really slow and start on a very low dose. And the provider should be reviewing a PMP, and that is it's a drug panel that you can see and it's state to state where they're getting their medicine, if they've been shopping around for doctors, if they've been filling and getting opioids from several different people. They need to be reviewing that as providers and be more aware. If they're giving out medicine, they need to know, is this person getting it from somewhere else? So, and then just the simple use of non-opioid treatment, and offer other treatments such as physical therapy, chiropractic care. There's just so many other things that can be used instead of one pill use. And here I found in a research article, it was talking about an ER that had implemented several different things they started with. And at first I was reading it and I said, oh gosh, this is different. But what they do, they have this protocol in order. If someone comes in with chronic pain, this is what they go to. This is their first line of defense, I guess you could say. So they start with Tylenol, ibuprofen. They do a lidocaine patch if deemed necessary, if it's like low back or something like that. Then they do naproxen, and this is what got me, the laughing gas. They have nitrous oxide in their ER, and they said they use it quite often. And I was thinking that might be addictive, but I did a little bit more research, and it was saying that it has a short half-life, so it's not as addictive, especially not as addictive as an opioid. And then they will even do regional nerve blocks in this ER, and it's cut down on their use of opioids. So that was pretty neat. All right, I want to thank you for your time. Does anyone have any questions? No? All right, thank y'all.